Good morning. Everyone can hear me okay? Yeah, okay. All right, so my only disclosures for the residents, don't do what I do in the hotel room, especially on Saturday. Pretty much none of this is safe for the boards. There's a lot of controversy in melanoma care, and it'll be a while before the boards is up to date, especially if you've been in clinic with me too. I'll give you a cheat sheet at the end for what you can say on Saturday. So the genesis of this talk really came out of a concept that was repeatedly brought up at our most recent society meeting, which is that over the last 5 to 10 years, our understanding of cancer biology has dramatically improved, largely from melanoma research and the emergence of immunotherapy, in a way that for the first time we're seeing improved survival in diseases that historically had very dismal prognosis. And that survival curve is continuing to shift in real time as we identify more personalized medicine with targeted therapies and combination strategies. There's probably a new clinical trial written every other day for X immunotherapy plus Y targeted agent plus or minus Z local therapy. So the concept of the adjuvant surgeon isn't mine. It was a phrase I borrowed from my mentor, Daniel Coit. And it's not meant to implicate that the surgeon has a less important role in melanoma care or cancer care in general, but just simply that as multimodality care becomes more and more complex and we're seeing neoadjuvant strategies employed in basically every disease now, that it really challenges one to be an oncologist first and surgeon second, especially when it comes to recurrent disease, advanced disease, and metastatic disease. So for the sake of time and getting to those concepts, I'm actually not going to talk about primary surgery. Not to mention the least of which is that with dozens of trials and thousands of patients and a mountain of data, melanoma surgeons in this world don't even agree on any of these primary surgical approaches. So I don't need to confuse you for that. But so my interest then is trying to basically break down this nebulous box. Because if you take care of a melanoma patient, you will eventually see a recurrence. And when you get to this point in the NCCN guidelines, it reads a bit like a buffet menu. So the question is, who is which treatment appropriate for? What's the risk and benefit of these? And how do you strategize? So this is a historic curve for melanoma survival. Prior to the invention of immunotherapy, basically what you see is that over about 25 years, we weren't able to improve survival at all with any of the various chemotherapies that were developed for other diseases during that time. Overall, one-year survival was very poor at 25%, with less than 5% of patients surviving long-term. So in that setting, with ineffective systemic therapy, we leaned on surgery a little more heavily in selected patients. Again, this is a huge bias for seeing this improvement in survival because we're talking about patients that, number one, had disease that was even amenable to resection. But amongst those patients, not surprisingly, patients that had a very small volume of disease and essentially soft tissue recurrences did see an improvement in their overall survival, such that now one-year survival with surgery becomes about 70%. Still poor long-term survival, as almost all of these patients will recur. But compared to unresectable patients, certainly surgery offered a small benefit in this highly, highly selected group. Then retrospective data from recurrences occurring from patients monitored in the MSLT1 trial were also looked at, since that was the largest volume of patients. And they found similar outcomes. Patients with very small disease in a good location, and then a disease-free interval of over a year significantly contributed to increased survival. So the role of surgery was considered to be that survival is improved in very select patients. That's still probably the answer on your boards if you get a recurrent patient. And then those patients are best selected by a long disease-free interval and soft tissue recurrence. But what about now in the era of immunotherapy? One can easily see that this curve is dramatically different than the ones I've shown before. And at 1 year, median survival is improved with immunotherapy to 24 months from 7 months previously with unresectable disease, and 20 to 40% of patients becoming long-term survivors. Now keep in mind that this is all comers. This is patients with multiple sites of disease, bad metastatic disease, rapidly progressive disease, and overall their outcome is still better with immunotherapy than the best surgery and the best selected patients. So then in the era of modern effective systemic therapy, who should we offer surgery? So this is just an example of the kind of dramatic responses that can be seen. I don't want to mislead you and think every patient has this response, but we think that our best combination immunotherapy is the CTLA inhibitor plus PD-1 inhibitor. You see a large chest wall recurrence there, and this is after just a single dose of therapy. At 3 weeks, you have a nearly complete clinical resolution, and radiographically, you see at 6 weeks, complete resolution. The challenge is we don't really know who these patients are yet, and immunotherapy is not without consequence. I won't spend a lot of time going over mechanism, but the simple mechanism of immunotherapy in general is that by attenuation of a T-cell response, you're able to improve the T-cell's recognition of tumor cells as well as the efficacy of their killing. And it comes in 2 flavors, as I mentioned, the CTLA-4 inhibitors and the PD-1 inhibitors. So what's our response with those, really? With ipilimumab, we have about a 10% response rate. That was the first developed drug. And we see an overall response rate of about 20% at 2 years. As I mentioned, the challenge is that it's not equal for all comers. It's really some patients are essentially cured and some patients have no result. We think the result with PD-1 inhibitors is slightly better. We see a better response rate, but these drugs are still in trial, so currently ipilimumab is still the only approved systemic therapy, and median overall survival hasn't been reported yet. So this is just a breakdown of those improvements, and as I mentioned, the combination therapy we now think is the most efficacious. We see at least a 50% response rate overall. It's pretty durable at a year, and the time to response is dramatically reduced to less than 12 weeks. But if you'll note, the adverse side effect profile is significantly increased, with 54% of patients having grade 3 and 4 adverse events, and many of these require hospitalization. So it's not perfect, and the challenge is then how do we incorporate that into an overall strategy to improve our surgical outcomes? So just a little bit about the goals of systemic therapy. There's really 2 flavors when you're considering whether or not this patient can be returned to a surgical candidate. And so a little terminology, neoadjuvant therapy would be systemic therapy with the intent to eventually take this patient to the operating room after a defined period of time based on our understanding of the systemic therapy's kinetics. These responses can be usually assessed radiographically or histologically, and postoperative adjuvant therapy may or may not be needed. Comparatively is upfront therapy when we initially take a patient that we think is not a surgical candidate or not resectable. We have no specific plans for surgery, but we have reason to believe they need systemic therapy up front. Response to the therapy can't necessarily be assessed, but certainly failure can if the patient relapses or recurs. So response kinetics is very important when deciding how long to treat the patient before surgery. We know a lot about the kinetics of these drugs based on previous trials in unresectable advanced disease. So what you're looking for is not only time to response, complete response, but also how long that response lasts. And that dictates the timing of any subsequent surgery. So I haven't mentioned B-Raf yet, but this is rapidly replacing immunotherapy as first-line therapy for B-Raf mutants. About 50% of all melanomas are B-Raf mutants. And we see pretty rapid responses early on with B-Raf inhibition. We rarely see a complete response, though, and it's also fairly transient. Now with the combination B-Raf and MEK inhibitor, we get a durable response to about a year, but we think more that the goal of this is really converting a patient into a surgical candidate, and I'll show you some cases in just a second. So this is an example of that metabolic response. In B-Raf patients, the metabolic response usually precedes the radiologic response. That being said, it's clearly dramatic. You can see heavy liver burden as well as bony metastases in the top PET scan. And then at just 2 weeks, almost all of that metabolic activity is quieted, even though gross tumor volume remains. So alternatively, the kinetics for immunotherapy, we see slower radiologic response, but we see more complete responses. And interestingly, if patients are responding, that response is typically durable, that even off of therapy, they're maintained without disease for years. And this is just an example, and again, this is one patient, but this is an example of what can happen with immunotherapy, such that the patient only received 4 doses up front. An initial response was observed. They were maintained on maintenance therapy, which is typically a dose every 3 months, and then they were taken off therapy. And then there you have it 1 year out. They have a complete response, and they're completely off therapy. Again, we don't know who these patients are, and that's one of the aims of the future of immunotherapy, is to better identify the genomics and the targeted agents that can help us identify which these patients are. So for the time being, who do you consider for neoadjuvant therapy and who do you consider for surgery? And should it just be resectable lesions? It's a little bit easier to advocate systemic therapy in unresectable disease, borderline resectable disease. But what about just lessening complications of bulky disease? Or what about any disease, since we know that all of these patients are at high risk for systemic relapse and death from their melanoma? So the first question is, how long do you treat? Since we don't have any well-defined randomized clinical trials, there's several protocols out there. One is from MD Anderson. This is with B-Raf inhibitors. They treat for 8 weeks and then proceed to surgery and have maintenance therapy for a year thereafter. 12 weeks is used in some institutions. Moffitt, who's another center of excellence in melanoma care, uses 24 weeks, and I'll get into the biology of why those differ in a minute. And then with immunotherapy, a lot of people typically say until maximal response, but again, given the side effect profile of immunotherapy and the risks that we think are associated with it, typically if a patient's getting immunotherapy, it's because they have severe disease, and so you push the therapeutic response as long as possible. So why 6 months at Moffitt? This is the most recent publication in Lancet looking at the B-Raf plus MEK inhibitor versus monotherapy. We think the response rate is significantly better for the combination strategy. And if you follow the red curve on the top, at 6 months with combination therapy, about 90% of patients are still responding, so they think that's a safe interval to wait to get maximum systemic response prior to proceeding with surgery. But for the average person treating melanoma in the community, if you're attempting one of these strategies, we really don't have an answer yet, and we may not for a while, given that there aren't randomized trials. That being said, the preliminary data is sufficient to suggest that we should be doing this for our patients if we want to offer them the best possible care. So I'll give you those cases. These are some of my cases since I've been here. First is a 42-year-old male. This is actually a typical story and something you might get on your boards. 10-week history of rapidly enlarging axillary adenopathy. Someone in the community tried to give him antibiotics. Somebody even tried to IND it. It didn't go so well. Comes to me with a fungating football under his arm that's super infected, quite painful. He's actually starting to have brachial plexus compression symptoms, can't sign his consent form. So one is very tempted to offer him an at least palliative operation, especially for wound control. He had a history of a benign pigmented lesion on his upper back, but of course biopsy of the axillary mass revealed that it was metastatic melanoma. And we sent this for B-Raf testing and it was positive. So I didn't give the whole PET scan, but I think you can clearly see that there's a problem. And that would be this hypermetabolic mass here that's replaced his entire axilla and is nearly the size of half of his thoracic cavity. So I would put this in the, at minimum, borderline resectable category, if not unresectable. We got a CT angio and the vasculature was okay, but again, we were worried about brachial plexus symptoms. So we elected to treat him with a B-Raf inhibitor. He's only 8 weeks out, so I don't have his follow-up films, but I have an example from Moffitt. So this was similar patient, similar location. They called this unresectable for similar reasons. At 6 months, it had almost nearly resolved. And I can tell you in clinical follow-up, my patient is now down to about tennis ball size, and so we're going to keep pushing it. So this patient from Moffitt eventually did go to the OR, and this is what you see on specimen. Dr. Sondak described this as being the consistency of toothpaste, and it was largely necrotic, which is confirmed on histology. And then this is what's interesting, is that only 4 nodes were positive with just isolated viable melanoma cells. So I'll come back to that pathology in just a second in comparison to the MD Anderson protocol. So this was considered a pathologic partial response. Second patient, 22-year-old female. She has a left thigh melanoma. Dr. Bold operated on her a year ago. She had 2 positive sentinel lymph nodes. She then underwent an inguinal dissection, had 0 of 23 nodes positive, and was followed clinically for the past year with PET scans. PET scan in January showed an in-transit recurrence on surveillance imaging. and she is a known B-Raf mutant. This is her recurrence. It's quite small and isolated, and one is very tempted to also operate on this, which is an acceptable answer and still probably, again, the right answer on the boards, and considered part of the standard of care in the NCCN guidelines. However, most of these patients will have another relapse and ultimately die of disease. Given that she's a 22-year-old patient with this high of a risk, we challenged ourselves to think of better ways to treat her than strictly treating her as having a local problem. This trial was just presented 2 weeks ago at the SSO from MD Anderson. So this is their protocol, the 8 weeks preoperative treatment, randomization to either surgery first or the neoadjuvant arm, and then proceed with adjuvant therapy postoperatively. And of note that all patients got the adjuvant therapy. So the only difference was the 8 weeks of neoadjuvant therapy. So they saw a pretty strong pathologic complete response rate in their patients at 60% at just 8 weeks. Survival was significantly improved for patients that underwent the neoadjuvant therapy compared to the surgery followed by adjuvant therapy. Median time to recurrence in the surgery-only arm was very short. It was 3 months. And this was also significantly prognostic to the patient, because if they fell in the group that had the 60% complete response rate, then their overall survival and remaining free of disease was much higher than the partial responders. So I bring this specimen back because it's interesting to the authors of these institutions that at 8 weeks of therapy, they had a better complete response rate than another institution that had partial responses at 6 months of therapy. So the question they asked is this really resistant disease that's on its way to dying, or is this the first evidence of a recurrence? As we know, all of these patients eventually escape treatment therapy. And so that's an interest in research of mine, as well as several of the members of our melanoma team. We look at different pathways that cause this resistance, be it new novel targeted therapies that will replace B-Raf in the future, post-translational modifications such as protein glycosylation, but there's a number of different strategies that we're all looking at as to how these melanoma cells sort of escape recognition by the immune system. So what about disease that's resistant in the face of immunotherapy and these so-called escape lesions that emerge later? This is a case from Memorial, 41-year-old female. She had an incidental lung mass noted on workup for abdominal pain. She underwent a right lobectomy and was found to have a melanoma of unknown primary, no additional disease, and was observed. She was treated actually with Timidar, which falls in that category of ineffective chemotherapy. In 2006, she had a right femur fracture. Workup revealed that she had lung disease, liver disease, and a pathologic fracture. So at the time, she was enrolled in a clinical trial of ipilimumab. She had a complete response by imaging and was then maintained on the Q3 month maintenance dosing. 3 years later, she developed this pelvic lymph node. So a lot of discussion was had about what to do now. Do we try new systemic agents? Do we offer her surgery? She certainly had a very long disease-free interval and falls in that category of isolated superficial recurrence, long disease-free interval. She's already seen pretty maximum systemic therapy. So she underwent surgical resection, and 8 years later, she remains free of disease. So this brings up the so-called 3 E's of immunotherapy that indicate what our goals with immunotherapy is. And the first is elimination, which we saw in all of her metastatic disease. The second is equilibrium. We think if there's a small volume of disease or slow-growing disease, that we can keep it under control longer. Or in the case of this pelvic node, eventual escape, in which case we have to change strategy. So the role of surgery in these escape lesions, there's not a lot of data. It's mostly small institutions that have been actively using immunotherapy and have enough patients that they can look at this. But this is from Memorial. So as you can see, not a lot of patients have really gone on to receive surgery after immunotherapy, but most of them were ones that had superficial masses or small bowel mets. This cohort breaks down the ones that were considered NED after surgery versus alive with stable disease and those that have progressed. And these bars are time to surgery. So as you can see, certainly disease-free interval continues to be a prognostic indicator of successful management with further surgery. And they also looked within these ones that were doing well, and typically these were lesions that were pre-existing and stable on immunotherapy as opposed to new disease that popped up after immunotherapy. Second interesting indication for surgery after systemic treatment is that we get tissue, which is not something you typically counsel the patient, but for those of us who research melanoma, it's very interesting to us to have the opportunity, again, to study why these tumors failed and to be able to improve our treatment strategies in the future. So the role of surgery in the area of immunotherapy, it's associated with improved survival in patients that are amenable and selected for surgery. Low volume and good disease-free interval are your indications. Responses, however, to immunotherapy overall are impressive, and we're working on ways to make that better. And we're still identifying which patients really do benefit, but it's also an opportunity to improve our understanding of the biology of resistance. Okay, so for the last part, I'm going to talk about management of more advanced disease that's typically unresectable. We have several options. There are surgeries that can be done. Even in the past, amputation was one of those strategies. Limb infusion, which we don't talk about very much anymore, but there's a couple indications for that. And then intralesional therapy, which is something this institution specializes in. And then, of course, how to use these in a neoadjuvant approach to improve our outcomes. So this is typical of in-transit disease. We have a lot of patients we've seen this happen to. About 3 to 10% of primary melanomas will develop this. I'd say it's even higher in our institution because we see a lot of rural disease come in with T3, T4 lesions that recur this way. It's a significant source of morbidity. Some of these patients do ultimately end up requiring an amputation just for wound control. But the greater risk is that over half of these patients will present with simultaneous systemic disease and ultimately die from their melanoma. So these are all the options that we have in our armamentarium to deal with advanced disease. So how do we choose which one to go with? First is to consider the goals of care, which is number 1, disease control, number 2, palliation, 2, to prevent recurrence, 3, to prevent progression, to see a durable response for the patient and to minimize the side effects of our treatment. So we've tried to come up with a bit of an algorithm on how to make this decision. And the first question is location. Certainly if it's a single-sided disease, again, it's tempting to want to offer the patient a resection. It also depends on if that's a palpable met, a cutaneous met, a brain met, a visceral met. So once that's assessed, if surgery is possible, that's an option. But hopefully I convinced you with the B-Raf and MEC story that that's not necessarily the way to go. So these are some examples of those kinds of superficial options. And certainly if we have a patient that is not a good candidate for immunotherapy, knowing the side effect profile, or certainly an older patient, surgery is still a very reasonable option for first-line therapy. Your local disease control is excellent. However, your control of systemic disease is fairly poor. There's a very high recurrence rate, as I mentioned, but it's well tolerated by the patients. This includes ablative therapies, which we won't get too much into, but a lot of new technologies are emerging. Cryotherapy is well established, but also electroporation is being used for some cases. So then next, what if the patient is not resectable? Well, my first suggestion would be the B-Raf testing, since we know we have agents that can convert this to a resectable patient, and then also to complete their staging, because certainly any evidence of systemic disease is going to change your treatment algorithm. So then moving on to systemic therapy. Certainly these patients fall into the unresectable category. And again, historically, that only option was chemotherapy, which was very poor at all of these treatment goals. So prior to immunotherapy, a lot of strategies were developed in order to figure out how to treat these patients in the absence of systemic therapy. And so isolated limb metastases were treated with limb perfusion or limb infusion, which I'll go over briefly. So this is an example of a perfusion diagram. It's done by a groin cut down and includes an axillary or inguinal dissection and then open access of the femoral vessels. Hyperthermic chemotherapy is delivered directly to the limb, and tourniquets applied. And this dose is 25 times higher than what you can achieve systemically. You perfuse for an hour at 40 degrees. And you get minimal systemic toxicity from this. You only get one shot, though, due to the open technique. And we also think it's better with the inclusion of TNF-alpha, which isn't available here in the States. And this is a comparison of Mefalan with or without the TNF-alpha. You do see some response, and it's fairly durable, high recurrence rate. But again, we think TNF-alpha is better. So certainly we've had patients in the past that if they had means to go to France and they had bad limb sarcoma or melanoma disease, they were referred abroad. So the alternative is also limb infusion, which we think is a bit more safe. It involves percutaneous access up and over. Again, a tourniquet is applied. And you don't have to have a perfusionist to do this. The surgeon there with the 60 cc syringe becomes the perfusionist and actively circulates the blood for about 30 minutes. So it's minimally invasive, shorter infusion time. And this can be done multiple times if the patient tolerates it. And again, this is done typically with Mefalan. So the results, complete response in about 40%. Median duration of that response is about 2 years. So why don't we do this more often? This is something that I was actually very interested in starting when I came here, and hopefully I'll show you why we don't do this here. So again, local control excellent, distant control poor, but good response and limited toxicity. So that leaves the final option, intralesional therapy with immunotherapy. So there's been a race to develop new fancy injectables, and there are many, many trials ongoing. There's currently only one approved therapy, which I won't get into today why that trial is not necessarily the most convincing, but that being said, the only phase 3 approved therapy is TVEC. But if you look at the NCCN guidelines, interlesional IL-2 is also on the recommended list of treatments, and that's what we use here. So its mechanisms of action can be direct chemical, mechanical ablation that causes cell lysis, as well as direct inflammation that promotes immune system response. A second interesting effect is called the bystander response. We've learned the most about this with radiation therapy of rectal cancers, where it's known as the abscopal response. Essentially, the local inflammation and treatment causes an adaptive response in the immune system such that distant sites of disease are also seen to respond without direct therapy. So lesions that are suitable are superficial, your dermal, subcutaneous, and superficial lymphatics. Deeper lesions are not usually first-line therapy for this, but certainly it's been done and tried somewhere. And so if you look at the NCCN guidelines and the references for this therapy, you'll see our institution is represented multiple times for our experience here with IL-2. And this is actually a diagram of systemic IL-2 injection, but it gives you the idea that what you basically do is cause local inflammation, primes the local T cells then to attack the melanoma. So results are impressive. You have this, in top, this is a in-transit recurrence. Basically, the entire forearm is involved, and with intralesional therapy, you get this robust inflammatory response. Now, you can't tell the patient that this is minimally invasive therapy necessary, because that's obviously quite painful and requires a lot of local wound care. But you see 100% complete resolution of all of his in-transit disease. And this is represented histologically, where here you see active melanocytes, and all that remains is melanophages, and they stay negative for melanin A. So this is another patient of mine that I also share with Dr. Bold. He recurred with in-transit disease very rapidly. It was about 6 weeks post-operatively. And so we referred him for IL-2 therapy. He had a great response. And what's interesting is you can see that the pigment actually stays, so you can see the previous sites of disease, but it's strictly melanophages. It's not active melanoma. And this one's definitely not safe for the boards. This is a lovely 96-year-old lady that presented with a thick lesion and satellotosis. She's relatively independent at home in that she at least ambulates and can get to the kitchen and get to the bathroom. Certainly the recommended surgery with 2-centimeter margins down to the bone would have fixed that for her. So we discussed being a little outside the box with her family, which was very understanding. And we did cryotherapy and intralesional therapy for 4 weeks, and she had 100% complete response. And she's back home and doing fine. So in our series of IL-2 injections, we see a nearly 100% complete response rate. So if response is so good, why even look at all these other many trials of all these other intralesional therapies? So I'll end on TVEC, and this is the bystander response, because we do think TVEC offers the bystander response, which IL-2 does not. So if you look at this patient in the example had bulky nodal disease, but the only injection site was this primary, which responded quite well, and incidentally the nodal disease was observed to disappear as well. This, however, was actually with Coxsackie virus. There's a couple of different strategies. But in the TVEC group, they did see a small reduction in visceral metastases. And you can see the lung mets. You can see the lung mets resolving as well, with only the primary being injected. So this is just a diagram of why we think that happens. Again, the local immune response is then primed such that that elevated response is able to attack distant sites of disease. This is the phase 3 study that gained TVEC's approval. They saw a complete response rate in only 50%, which is certainly less than IL-2. Overall response rate, 64%. But they did see this response in the visceral metastases at 22%, and a partial response at distant disease at 9%. So local therapy offers high local concentration, certainly palliation of disease. It may induce the systemic immune response at uninjected lesions. And regional and distal control may be reasonable with bystander response, which is one reason we're interested in looking further at TVEC. Now, some of this is data from Amgen, which of course wants you to believe that TVEC cures everything. So this has not been compared direct head-to-head, but that being said, if you compare it to best systemic therapy, objective response rate for TVEC alone appears to be adequate and comparable to systemic therapy, if not better. And this is the recurrence-free survival curve that they've generated after treatment with TVEC, which compared to those previous survival curves has certainly shifted to the right. And one of the reasons they argue this happens is on the right, you're looking at the occurrence of visceral metastases after TVEC treatment versus overall survival compared to patients that went on to develop the visceral metastases. And so they saw that overall, there's a 59% lower risk of developing visceral and bone metastases with TVEC treatment. So with that being said, we think that intralesional therapy offers excellent local control, possibly distant control. It's very well tolerated and a durable response, which is why we haven't really pursued the limb infusion. So I would add to our macroscopic algorithm that certainly there's a role for neoadjuvant treatments to improve response, and that may proceed to getting the patient to the operating room. The benefit of that neoadjuvant therapy is it gives you a marker of whether or not this is tumors of good biology and will respond. It gives you the opportunity to obtain tissue. Endpoints can be achieved in smaller trials, and studies are ongoing with resectable advanced disease. And the very last thing I'll end on is that amongst these numerous trials, I'm trying to add one right now with my cohorts at Emory and BU, and that if we're using this neoadjuvant strategy in advanced disease, why not use it in early high-risk disease? So we know that tumor thickness is almost as prognostic as lymph node status, and that T3 ulcerated and T4 lesions have significantly poorer survival than T2 lesions, and ultimately most of these patients develop relapse. So we're randomizing to neoadjuvant TVEC in these T3 and T4 lesions to proceed straight to normal surgical resection versus 4 weeks of neoadjuvant TVEC followed by standard surgical resection, observing for overall endpoint of distant recurrence-free survival. So the role of surgery, it's not obsolete, I'm happy to report. Neoadjuvant therapies are becoming routine, especially with B-Raf inhibitors, with immunotherapy to follow. And we continue to aim for strategies to improve survival with novel combinations and personalized medicine. So a lot of things will change in the future. Surgically, there's lots of ongoing trials, especially with minimally invasive approaches to melanoma, as well as personalized medicine with genomics, trying to predict which of those patients are at high risk, but none of that's really ready for prime time. So these patients should be treated in a multidisciplinary setting. Regional control is possible. We aim to prevent distant metastases as part of our treatment goal, as well as palliation of the recurrent disease. and neoadjuvant and multimodality therapies are needed for optimal treatment of these diseases. And ultimately, that's because biology is king, and there are things we can't do with surgery. So I'll take any questions.
So thank you. That was really a spectacular review, and I also think a great reminder of the importance of, lifelong learning. This disease has changed a lot. Certainly when I started, forget it. The metastatic melanoma was a death sentence. And the results you've shown are really impressive. So it's great. And that the role of the surgeon is not just sort of cutting it out and not thinking about it again. And the importance of the reminder, so for the boards, if any time you come up with a cancer, the first question is, staging. Then you figure out what the surgical potential options are or not. And so I love the concept of the adjuvant surgeon. I think that's really a great approach. So, questions from the audience?
Man, I really enjoyed your talk. I was wondering if you could comment on, if you know, what the medical oncology perspective is about the role of surgery for these patients. Are these patients that you guys are having to fight to operate on, or is medical oncology on board with this multidisciplinary approach?
Certainly depends on the institution and the patient, but I think I've certainly had patients referred to me since I've been here that have been on systemic therapy for 2 years with one stable site, and they want to come off therapy, and we proceeded with surgery, and I think there's been a pretty good relationship in discussing those complex cases.
And are there people you think who are just staying on systemic therapy that you're not hearing about?
I don't. I think our institution in general is a bit immunotherapy shy because of the complication rate. I feel more often I have to push if I really think a patient should be aggressively treated with adjuvant systemic therapy.
Dr. Person?
That was a great talk, thanks. I was curious if you could comment on the role of the new PD-1 inhibitors that are now being advertised for lung cancer on TV now, and what the role is in melanoma for those kind of drugs.
So we definitely think they work better and they're better tolerated. None of the clinical trials are completed though, so it's still considered off-label, but we have, like I said, there's dozens of active trials of Pembro plus XYZ that, we have one here that's Pembro versus IPI, but it's a little interesting in the surgical question that it raises that in order to be eligible for the trial, you have to have completion lymph node dissection, which I don't practice routinely, and so it's just an ongoing discussion.
What specifically about melanoma do you think responds so well to this immunotherapy? And is it just that melanoma is the first cancer? Is it just this proliferation rate? And will we be using this for all cancers?
So if I think for melanoma, it's because they have such a high mutational rate, especially when you look at the initiation of immunotherapy over time. It was patients that have been treated with chemotherapy and evolved and mutated, and they have such a high mutation rate that it makes them very immunogenically hot. But we're obviously seeing a role for immunotherapy across the board.
So the concept of giving a CTLA-4 inhibitor to enhance the immune response is kind of the opposite of what we think about in transplant, where we give it to suppress the immune response against infections. So the side effects that we see are infectious complications because of the immune suppression of the tumors. Do you see any of that in your patients? Are they prone to infections?
Typically not infection, it's more of an autoimmune disease presentation, so they get lots of diarrhea, GI side effects, vomiting, dehydration. I don't think we see quite as much infection, but certainly.
So you don't give antibiotics or antiviral agents because you could be suppressing host response
Right.
to viral infections. We typically give them antiviral at least for a period of time. Do you do that?
No, not routinely.
So I think there's a potentially really interesting conversation that could happen here about, what are the different perspectives on using the same drugs for different indications. I was impressed, and I hope it wasn't lost on the audience, the age range of the patients that you treat from, the 22-year-olds. I certainly know we saw like a 9-year-old recently with melanoma, that as well as your 95-year-old, and that it's a disease that I think all of us, again, living in Northern California, are need to be mindful of on a personal level as well. So thank you so much for bringing this to us and bringing the sort of rigorous approach to this disease. So I want to ask you, you made the comment that you thought you wanted to bring limb perfusion when you came. Sounds like you've sort of drunk the interlesional Kool-Aid that Davis has advanced, but where's your thinking now still about the potential role for some more limb-related perfusional approach?
I think certainly if it crosses the joint, if it's been refractory to immunotherapy systemically, you may see less of an effect. We've had a profound response with IL-2 with I think only one person having a recurrence. So it's hard to argue against that, but definitely there will be patients that fail.
Are you planning to still proceed with trying to develop the technology here?
Mm-hmm, absolutely.
Great. Any other questions? Thank you again. Great work.